Welcome to Medical Minutes See Beyond with Infrared Imaging. And today we received the Professor Robert Kane, talking and sharing knowledge elements about thermal activity of estrogen on breast and signal activity, estrogen, infrared imaging in the breast. Sorry. Okay, Professor Kane, welcome. Are you sharing your display? Please check it out. Welcome to Medical Units.
Great, thank you. It looks like the screen share is working fine. First of all, I'd like to thank the AAT and Dr. Broski for allowing me to speak and share some of this information that I've been working with over the past 20 years. The presentation here is signals of estrogen activity in thermal breast imaging. And this is important because estrogen appears to play a role in many different breast conditions, anything from benign breast disease, such as breast cysts or fibrocystic tissue, to breast pain, mastodynia, and of course, risk for breast cancer and being a primary driving force for existing breast cancer. Many cancers are estrogen positive, so the ability to understand what estrogen is doing in the breasts can be helpful in management as well as detection. Now, thermography or thermal imaging is a neurovascular test and can visualize the superficial circulation in the breast. We can see that there's, of course, deeper circulation going on, but for the purposes of thermography, we are really looking at that top half centimeter. So any deeper types of lesions need to create some sort of expression on the surface of the skin in order to be visible. Now, estrogen physiologically will promote vasodilation, and it does this by stimulating prostacyclin production and nitric oxide synthesis, along with inhibiting vasoconstrictor agents. And this is important because what it tells us is if we're going to be looking for a signal of estrogen, we need to be looking at vasodilatory situations, so heat occurring in vascular patterns. This information was taken out of the Brazilian Journal of Medical and Biological Research in 2003. Now, by analyzing the vascular patterns of the breast, we may be able to visualize the effects of estrogen on the circulation by looking at those levels of dilation. But to do this, we need to identify normal vascular patterns on the thermogram and how they would change with estrogen stimulation. Most thermal analysis for breast is really looking at asymmetrical patterns or patterns that are more consistent with neoangiogenesis and cancer-induced blood vessel growth. And while that's absolutely critical for looking at breast cancer detection and breast cancer monitoring, with estrogen, we're going to be more concerned with these normal patterns that just happen to be particularly warm. So let's talk about some of these normal patterns and how they might present. There was a pamphlet put out, or actually it was a publication put out called Dynamic Telethermography in Clinical Oncology, put out back in 1973. This was a while ago. And Gerard, Atschulat, and Marek, who were the mavericks in breast thermography at that time, basically came down to create 4 classifications for normal vascular patterns based upon 5,000 breast thermograms. So these are healthy women, no evidence of breast cancer. What did we see in terms of these normal patterns? The first one is an avascular pattern. I've got a schematic up, and I've also got some very old images just because this is the original research. I will share with you more modern images so that you'll be able to get a feel for what it would look like in your own practices if you're working with this. But the idea here is that really we have very few vascular patterns. Notice the vascular patterns that are shown are symmetrical. If we look here, this is a black hot, white cold image, also known as inverted gray. And what we're seeing is a little bit of black lines right here representing the vasculature. So the type A is avascular. Type B, we have a moderate level of symmetry. Now, we're not going after precision engineering symmetry where everything is perfect from right to left, but just a reasonable level showing us that there's a fair amount of symmetry between right and left within the tolerances of anatomical variation. You can see here we may have some different blood vessel structures that are being affected, but overall, we're not looking at a grossly asymmetrical situation. Symmetrical symmetric, or type C, is when we get more of the breasts involved. We have a fair amount of dilation going on, and in this case, it's extending to the level of the nipple line. Again, a fair amount of symmetry, but certainly more dilated than and warmer than those initial thermal images we looked at with the type A and even the type B. And lastly, type D is the most involved level of thermal dilation. And in this case, they called this a check pattern because there's so much dilation going on. We're actually seeing how the vessels anastomose and meet up with each other. So instead of seeing fragments of blood vessels, there's a significant level of dilation and a significant level of heat coming off of these so that we're actually seeing the full blood vessel structure. There was a last designation that they made called type L, or leopard pattern. And I bring this up because many thermographers currently believe that this is the signal of estrogen. And, I'm not quite sure I agree with it, because really in the leopard pattern, we get this mottled appearance where we get hot spots, and you can see over here, not only do we have the heat, but we also have kind of blurring of the surrounding tissue. This to me is more of a straight sympathetic nervous system response. We see it with hot flashes, or if a patient's too warm and has not been properly acclimated. If they're very upset or emotional, we've seen these types of patterns. And this can be a sign of some sort of dysautonomia. The regulation of the autonomic nervous system is not working ideally or properly, and it's creating this kind of flushing reaction. So when we're talking about normal vascular patterns, I want to concentrate on those first four. Now, how does estrogen influence this, and how does this relate to what we've just seen? Well, Dr. William Hobbins, who was a breast thermographer back in the 1960s, 70s, and 80s, very learned man, was responsible for many research papers, personally read over 500,000 thermograms, and had his own research clinic out in Wisconsin. He noted that there were certain vascular changes that we noted during pregnancy that he believed were estrogen driven. Prior to pregnancy, he was noting that prior to pregnancy and lactation, the breast is relatively avascular. And that would occur to mostly type A, but a little bit of type B if it's not that developed. As estrogen increased in pregnancy, the vascularization would increase from the upper quadrants to eventually cover the whole breast. And now we're looking at the type B, C, and D forms. When higher types, so B, C, and D, are seen in a non-pregnant, non-lactating woman, this could be a signal to state that the estrogen activity is higher and could be associated with some of the conditions that we had noted before. Now, notice we're talking in terms of estrogen activity versus estrogen concentration. I'm going to go ahead and explain that a little bit more in depth as we go into the presentation, but we're really looking at how active the receptor binding sites are versus the physiological concentration of estrogen in the breast. Now, it's important to understand that when we're looking at this and we're trying to make conclusions regarding estrogen, that we include additional considerations. Number one, thermography does not diagnose any hormonal condition, so it's not specific to estrogen. There are other things that can cause these hormonal dilation response, or not hormonal, but these dilation responses that have absolutely nothing to do with hormones. So we need to consider those other causes, and those would include inflammation, infection, compromised lymphatic circulation, which would lead to inflammation, vasoactive medication reactions, and bilateral breast trauma or surgical alteration, leaving some of the vasculature in a state of suspended dilation. And lastly, normal variation. So as I present this material, please understand I'm not presenting this as a conclusive evidence of thermal signals, but I'm looking at potential thermal signals that require a certain amount of differential diagnosis so we can understand what's causing them and then see how we can utilize them in our practices. So how can we use the thermography to help assess estrogen activity? Well, to do this, I think we need to come up with some sort of grading system that'll allow us to understand the severity of the potential activity that we're seeing. When we see these things, we can then do our differential diagnosis, rule out some of the other possible causes, and see if we're left with something that's going to help us understand the estrogen activity. So we're going to use the normal patterns that are identified by the Girard study. And then we're going to combine this with the vascular effects that pregnancy and lactation create on the breast physiology. So if we look at this, this would be a hormonal grade. I would call it 1. I've graded these things in 1 to 4 in my practice. And what we're looking at is that low estrogen activity, type A from Girard. Now, these are more modern images. This is off of a Bales camera. This is liquid nitrogen base, so very stable, but certainly the resolution is up 320 by 240. We can see the vascular patterns on the white hot image here on the chest wall, but not many in the breast itself. We can see it in black hot as well over here. Excuse me, yes, in black hot. Now, there is a debate in the breast community whether inverted gray or black hot is the scale of choice. I love debates because everybody's got an opinion and we all argue with each other and have a lot of fun. But the reality is I look at what catches your eye. I think that we need to have some sort of gray analog scale rather than those block gradient scales in order to see vascular patterns. But for me, sometimes I see it better in white hot and sometimes in black hot. So I actually routinely go between the two. If then we move to a hormonal grade of 2, we're now looking at type B from Girard. We're now getting these vascular patterns more into the upper portion of the breasts. They're into the globe of the breast versus just the chest wall, showing that we have a potential for more stimulation. Type 3, we're now really looking more at situations that would commonly be seen during pregnancy, during lactation, or somebody's taking exogenous hormones. In this case, we're down to the nipple line, but notice the fair amount of symmetry here. Again, with the black hot, sometimes this pops out a little bit more. I just put them in both scales because everybody's eye works a little bit differently. And honestly, I find that often I'll start off in black hot because I pick up the big stuff. And then I'll work my way to white hot. Excuse me, I start off in white hot and then move to black hot in order to see what I might have missed based upon the changes of the color scale. I find that playing around with these color scales and these palettes actually can show me things that I might miss if I was only looking at things in one palette. Lastly, we're looking at type D Girard, where we're coming below the nipple line. Again, very highly vascularized, and the whole breast is involved. Now, again, my caveat from the prior slide is that we have to differentiate these things from other causes. So, for example, if I found that this woman was on a very highly vasoactive medication and that she just recently began taking it, I would consider that that might be a possible cause of this. But if I have a woman who's postmenopausal on no medications, there's no history of anything that would lead me to believe that any of the other possible causes are going on, well, now I can sit here and say that this may be suggestive of some sort of estrogen activity in the breast tissue itself. Now, clinically observing this over the years, what I've noticed is that for women over 20, premenopausal, they seem to be in grade 2. There's enough circulating estrogen going on that they seem to have a little bit of symmetrical vascular patterning going on in those upper surfaces. And that's fairly typical. I use the age of 20 because I have noticed in the few women that I've imaged that are under 20 that we tend to get higher grades because they are in puberty. There's more circulating estrogen, and we do see more higher levels of symmetrical patterning. Now, I noticed with postmenopausal women, because estrogen circulation tends to drop, most of them end up in grade 1. And then when we're looking at pregnancy, lactation, or some sort of exogenous estrogen situation, then I've seen them more in the grade 3 and grade 4 rating systems. So now what can cause elevated breast estrogen activity? We now have a way to potentially narrow down that it might be occurring. What are the things that can actually cause it? Well, number one, endogenous circulating estrogen is definitely going to cause it. So if a woman has some sort of estrogen balance where she might be producing more estrogen than normal, we may see more stimulation. Also, remember, we talked about that we're looking at activity versus concentration. So if a woman has more sensitive estrogen receptors or a higher number of estrogen receptors in her breast tissue, she may be more reactive to the circulating estrogen that's already there. Pharmaceutical estrogen, birth control pills, hormone replacements. I don't put this up as a negative thing. It's just we're trying to explain what we're seeing. So if we see a very vascular breast, but the woman is on birth control pills or hormone replacement, we've explained it. It's not going to be some other type of cause which might require an intervention. It's simply a physiological function of the treatment she's already on. Number 3 is very important, which is aromatase conversion of androgen hormones. After menopause, women do not go down to 0 in terms of estrogen activity. The production basically transfers from the ovaries to the adipose tissue. And through aromatase, we're now converting testosterone to estrogen in order to maintain the estrogen supply. Now, where is the main adipose in women? Well, certainly anywhere where we could see fat buildup, but even in a thin woman who has a very low level of fat percentage in her body is going to have a higher percentage in the breast tissue itself, which is primarily fat, and also the thighs. Now, an interesting study done in 2000 that was published in the Journal of National Cancer Institute Monographs actually showed that in breast cancer patients, the level of estrogen, and this is the concentration, in a breast cancer patient can be 50 times greater than the blood. So if we're sitting there and just measuring blood concentration of estrogen, this postmenopausal may show low estrogen. But if we actually assayed the tissue and looked at the concentration present in the tissue, we may find that it's significantly higher. And to me, this is one of the single biggest reasons to explore this application of thermography, because currently we don't have anything that's breast specific, and thermography offers a potential to provide answers in this area. Another one we could talk about is poor metabolism of estrogen. Estradiol, which is the most prevalent type of estrogen, has to break down to be metabolized and eliminated by the body. The metabolites themselves can bind to the estrogen receptors and actually simulate the effects of estradiol. Now, one particular metabolite, the 16-hydroxy, actually has a higher affinity to bind with the receptors than estradiol itself. So it's considered more active. And indeed, even in the holistic communities where many doctors are working with nutrition, supplementation, things like that, what they found is that these ratios between the different metabolites that are caused by the breakdown of estrogen can actually have an effect on breast cancer risk. Also, we may have a concurrent condition affecting estrogen metabolism. One thing that we've noticed too is that it's very common for women that have thyroid problems to also have a problem with metabolizing their existing estrogen. So these are all possible reasons why the estrogen activity might be actually elevated in the breast tissue. Now, phytoestrogens and xenoestrogens are basically either plant-based estrogens or chemically based estrogens that affect the body, and again, can accumulate in the tissues and also raise the activity. So let's look at tests that we use with in order to evaluate estrogen and see where thermography might actually fit here. We have blood tests, which are important because they'll tell you the circulating measurement of estrogen. And of course, that's always the place to start to find out what's going on with the patient in terms of their hormonal balance. Urinary tests have actually been used to look at the metabolites. So in a case where the blood test shows that there may be either a normal or a reduced level of circulating estrogen, the urine test might actually be able to sit there and say, is the breakdown of estrogen occurring in a way that might be overstimulating the breast tissue? Salivary tests are a little problematic because the accuracy isn't so great, but it's attempting to measure tissue uptake of estrogen. The theory behind this was that when we measure circulatory estrogen, that's what's in the circulation. But what are the tissues actually taking up? Well, in addition to general accuracy problems with saliva, the salivary gland does not produce estrogen, whereas the breast tissue actually does. So even if the salivary gland measurements were more accurate into themselves, this may not translate into what's actually happening in the breast tissue because breast tissue is an estrogen producing organ. Thermography is indirect, and we do have some of the issues we talked about, other causes that need to be considered before we jump to estrogen, but the data is very breast specific. And because of that, it can be helpful in knowing, is the breast overstimulated by estrogen? We just have to be willing to deal with some of those setbacks and some of those limitations by the other possible causes of the dilation. So now what can be done in that situation? Well, balancing the hormones is the key here. I would say first off, and this isn't on the slide, if we think we see something that suggests estrogen stimulation, the first thing to do is to start looking at the whole clinical picture, start to systemically rule out some of the other causes of the dilation, and then start looking at what might be causing the stimulation in the breast if that's all we're left with. If the hormones are out of balance, we could take a look at this. Interestingly enough, some of the doctors that I've been working with have noticed that bioidentical hormones tend to have less of a stimulatory effect than the synthetics. So it could be an indication that the patient would do better on a bioidentical approach versus a synthetic approach. We can look at optimizing estrogen metabolism, driving the pathway so that the byproducts do not stimulate as much. We can look at addressing the use of phytoestrogens. So phytoestrogens are the plants that actually cause estrogen production in our body. Soy is a big one. We've noticed just anecdotally in the practices that I support that when women are eating a lot of soy, they tend to show more stimulation on their breasts. And then addressing xenoestrogen exposure, chemicals that are in the environment that might start to bind to the estrogen receptors. And lastly, addressing other conditions which have effect on estrogen metabolism. If there's a thyroid concern, if there's a concern in the microbiome of the gut, these might be areas to consider as possible access ways to improve the metabolism of estrogen. And then lastly, improve the lymphatic circulation. When the circulation is stagnant, we tend to get less flushing of the receptors and things start to build up. So in conclusion, thermography can demonstrate elevated estrogen activity in the breasts that may not be detectable on other tests. The elevated estrogen in the normal breast may be a factor in benign breast conditions and potentially be a risk factor in development of breast cancer. And the ability to identify and monitor a possible state of elevated estrogen activity can aid in the overall treatment and management of the patient. And that's the end of my presentation. I welcome your questions and also your ideas. I understand that this approach has its limitations, and I'm certainly interested in anyone's ideas on how we might be able to overcome them. Research that might be something we can explore together in order to see if we can narrow this down to something more concrete. But obviously, I think this is important enough that even though it's not at a conclusive stage in terms of proof and evidence, that it's worth exploring together as a community because it does tend to, it does have such a significant impact in terms of women's health and breast cancer in general.
Red talkie powder.
Thanks so much. Thanks so much, Professor Robert Kane, for this amazing presentation on estrogenic thermal signatures on breast. I think your work inspiring and very near future for many heavy thermal correlations to apply it to elevation of estrogen activity by infrared imaging. Professor Marcos Brioski, please avoid.
Congratulations, Kane. It's very important, this presentation. I like a lot. We must to spread this option for many doctors that have hormonal approach with the breast. So when you told that it's thermography is not something to diagnose hormonal problem, but if we put together other pieces of this puzzle, I believe it can help a lot as a biomarker, and especially to follow the patients in a better way, much better than to do blood exam, saliva, and also with infrared, it's very good. And there's an interesting point that we could discuss is about the effect of estrogen, because estrogen we must think as a neurotransmitter, like because they influence the vascular tone. So the estrogen they have interacts with receptors in the brain and the blood vessels and here in the breast. So they release the nitric oxide, as you told, and relax the blood vessels when it's high. And when you show the classification, I would like to discuss 2 points. One is the grade 1. The grade 1, many research they use the name avascular, and we are not using so much this name avascular. We prefer non-vascular because sometimes avascular has a connotation of ischemia or lack of blood supply. For those that don't understand the infrared image, so I know there's vascular here, so it's a little confusing. And when you use a vascular, and the second thing is the hot flash, the leopard sign. I believe it's something very interesting because some doctors don't understand how it's possible to have a dilatation with vascular hotspots as the leopard if the estrogen is low. But we must understand that the estrogen is a neurotransmitter also in the brain. So when the estrogen is low, the hypothalamus change the thermoregulation, and they feel that is wrong the temperature of the body and try to elevate temperature and doing that hot flashes. So the hot flashes is not only on the breast, but you can see on the face, on the back, and this thing. So, but very, very good, Kane. And if you could you please comment about that, about terms vascular, non-vascular, and the other things? It would be very good.
Yeah, I mean, I think you said it very well, Dr. Bielski. It's This is thermography at the very basis is a neurovascular test. So we're looking at heat as a function of superficial circulation, and then that's completely controlled by the sympathetic nervous system. So anything that affects the sympathetic nervous system will affect the heat. And in a situation with the leopard pattern, we're looking at I think it's just a thermal reaction. I've seen those patterns from the hot flash. I've also seen it from a warm body temperature. It's the way the body actually responds to the laboratory being too warm. So someone comes in and the laboratory itself is, let's say, 24 degrees Celsius rather than 20 or 21. They're already warm. And we see this modeled pattern. And physiologically, it's interesting. I'm trying to think of the detailed physiology of what causes it, because we do have kind of combinations of cold and hot. My suspicion, and I don't want to represent this as literature, but my suspicion is that the vasodilation is producing the hot, but the cooling is basically a blurring effect, because the heat pools outside of the body, and in a sense it forms almost a heat shield around the body. And you'll notice on these modeled appearances, they're also very blurry. It's hard to get a clear, crisp view. So I think there's a certain amount of heat buildup superficially that's also contributing to that particular presentation. Certainly a hormone situation could cause a leopard pattern, but it's nowhere near exclusive to it. And I think, at least my clinical experience has been, these other dilatory patterns, the symmetrical ones, seem to be more reliable predictors than just looking at those modeling patterns.
And in this situation, as you told on the last meeting, it's very important to control the room temperature, to wait 15 minutes to do this image, because here it's very critical to take care with that. It's totally different when we talk, for example, for point of care. Point of care is just something very fast, just to have idea. But here is different, because we need to monitor, we need to have accuracy, and the difference between 1 month and other is not so much. So we must to take care to understand and how to follow up with this woman. And especially, I believe we can adjust the doses of the hormones, or permit or not permit use of that based on the infrared image. Are you there, Rita? Are you there to comment something? If you want to do in Portuguese, no problem. I try and translate to him. Does anyone want to do a question? It's a great opportunity here.
Yes, Rita do not start, Marcos, for the moment.
Does anyone want to make a question about breast thermography? Yes. Oh, go ahead, please. We'll talk.
Yeah.
So good afternoon, everybody. Thank you, Dr. Kane, for your great and amazing presentation. I found it very interesting. I would like to know, how does your approach take into account confounding factors such as emotion, as you mentioned on your presentation? So, for example, you mentioned that for menopause, we could find a type 1, but what about if this patient is suffering, for example, depression, or is very shy and you are just taking the thermal images? What could we maybe find in those thermal images, and how can we analyze it later on?
Yeah, it's a great question. And, a lot of this has to just be done in the clinical approach. So what I've seen is that when we talk about an emotional reaction thermographically, it's usually some sort of acute emotional reaction. So, for example, if I had patient A standing there and I went ahead and started talking about something very upsetting, and they were visibly getting upset, well, thermally, we should see changes reflected by that. In the situation where someone is just on an ongoing overall depressed, let's say they've got a fibromyalgia situation and they've got chronic pain and they're just, or just having horrible menopause symptoms and it's become depressing. I see less of a dramatic effect in those situations because the body's almost gotten used to it. Not that there's no physiological effect, but I haven't seen the dramatic leopard patterns and things like that caused by that type of emotion.
Okay, thank you. Great.
I have a question, Professor Kane. Professor Kane, again, amazing works. Do you have any experience with thermal patterns in mastectomies in women on estrogen thermal signature patterns in the breast remaining? Have you understood my question?
Ask it one more time. I missed a couple of words and I want to make sure I get it 100%.
Sorry?
If you could repeat the question, I missed a few words that you were saying.
Okay. Are you have experience analyzing patterns on the mastectomies in women over the remain breast patterns of estrogenic thermal signals? Are you experienced about that? Can you explain, please?
Yeah, it's a great question, and I've seen quite a few of them, and in some ways, it's the great mystery because every mastectomy is a little bit different based upon the surgical approach that they do. So there are certain things that uniformly seem to be consistent, and a lot that's completely inconsistent. If I'm trying to grade a mastectomy region based upon, let's say we're looking at breast cancer risk. So for example, with a normal breast, we'll grade it on a scale of 1 to 5 based on the TH rating. I don't believe that we could do that because we don't have both the qualitative and quantitative findings anymore. And we're dealing with remnants and altered tissue. So I do find that the mastectomy region is generally warmer than the other side because there's less fat insulating that area. So it's expected that it's going to be a little bit warmer. But what I do is I look at that compared to the clavicular region and the axillary region to see if that warming extends to those areas and that might be a potential sign of risk. I wish I could tell you that any of that was researched, but it's not. That's just clinical experience and using applied physiology to try to give some sort of information to help a woman understand that there may be a situation going on that she needs to pay attention to. I'd say the biggest thing for mastectomy patients is get that baseline post-surgery after the mastectomy is done, after it's healed, and after they've completed radiation. And make sure it stays either stable or improves. Because the big finding that I've seen with mastectomy patients that has cued me to a reoccurrence is that this situation, whatever it is, this physiological situation of the mastectomy, temperature pattern got worse. So we watched it in 3 months, and we're now seeing increasing levels of heat building up. We're seeing new vascular patterns. That has to be explained. And even then, it's not diagnostic, but we have to explain why someone who had cancer, which creates angiogenesis, is now seemingly creating angiogenesis again. And then that information could be used. So when people work with me and I'm reading their images, I grade mastectomy on a low, medium, high risk, just literally that, and it's based upon qualitative patterns only. Does the mastectomy look very, very hot, excessively hot? And do I see involvement in any of the lymphatic regions? I would love at some point to do more formal research and start to see if we can demonstrate quantitative data. So, for example, if it's a 1 degree Celsius or higher difference between side to side, that would be considered significant. We don't have that at this point. I think I'm one of the few people in breast that's even paying attention to it in the broader scale. But I welcome collaborative opportunities for research on all of this.
Thanks so much.
Thanks so much. So, other common question is about implants.
Yeah.
So many thermographer, when they're starting, they have doubt if the woman implant is possible to analyze this estrogen effect or not. What is your opinion about that?
Yeah, at this stage, well, implants, yes. For the mastectomy is different because there's so much alterations. I don't think you can really accurately look at what's happening with the blood vessels to do an estrogen analysis. But for implants, what I've noticed is that overall the breast is cooler with most implants because we're just putting more tissue material in between. The materials, the silicone or the saline, produces an insulative effect. But we usually can still see those patterns up on the chest wall in the upper portion. And in the case of more severe cases, we do start to see them into the breasts. What I will say is with implants is the effect is not as dramatic. So I would say that there's some compromise to this analysis with implants, but it's not completely invalidated.
Okay, is my opinion too. It looks like it's more easy, but we must to take more careful because it's a artifact, but not. But we must take care, sure. And other thing interesting is in US is very common the woman doing breast drainage, lymphatic drainage, especially after doing some thermography and or not. But what's your opinion about that? It's really changing the local, or do you think it's just, or there's no change after lymphatic drainage? Not during for example, 1 month or 2 weeks, because the hormone is there. If it's high or it's low, it's be increasing and changing. So, do you believe that lymphatic drainage really can help on this?
Yeah, I believe it can, and I've seen it help. Now, I'm not going to go as far as saying it helps every single time and it's the panacea, because it's not. We have to always ask what's causing the situation and what are the components. But what is interesting is that early on, I'd say probably when I first started looking at the stuff in 2003, 2004, we had doctors that were experimenting with progesterone cream based upon William Hobbins's research. And they would rub progesterone cream on their breasts to try to combat the estrogen stimulation. And they was getting a certain amount of results. So I was recommending that to some of the people that I was working with, as long as it was appropriate for that patient. And we would notice in that the population where that didn't work, sometimes it was the lymphatic massage that did. So I think the important thing to remember is that we have different reasons for why this situation occurs, and the treatment has to be tailored in order to address that particular reason. So the more differential diagnosis you can do to identify possible causes, the more access points you have. Now, one of the nice things about lymphatic massage and some of the supplementations is that they're generally regarded as safe, meaning there's no side effect negatively of the intervention. So in that case, we actually have the possibility of having the clinical trial be part of our differential diagnosis, meaning how did we know that the lymph was an issue? Well, we circulated it, we massaged it, and we got the results. So in retrospect, we can make the assumption that this had some sort of effect.
And comparing the massage with 3-indole carbinol, DIM, some pills, some oils, do you believe is better, is the same, or depends? Nobody know have these answers so well.
It was the last one.
Yeah.
It depends. Nobody knows. The thing is about a lot of these interventions is that the research that was done on them was mostly from a mechanistic standpoint. How can it physiologically affect a particular condition that could cause the thermal aberration you were seeing? But nobody sat there and actually done comparison between lymphatic massage versus nutritional intervention. Nobody's gotten to that level of research, and it's part of what's hindered this. There's not always money for research. We've got clinicians doing it, not researchers. It's an area that I would love to explore much more in detail.
But do you have some cases with benefits after these treatments? Do you have documented some cases, for example, that the woman used one of these treatments and changed her? Yeah.
Yes.
So this is good. This is a good start to
yes
to now to understand and see the confounders.
Yeah, I've seen it with indo-3-carbinol. I've seen it with diindolylmethane.
Okay.
I've seen it. So those are the two major ones that were used in the breast. I've seen it with progesterone cream. I've seen it with lymphatic massage, but not every one of those things works every time. And I think from a standards of care approach, we need to start dialing into what are those factors that would determine whether one treatment versus another would be beneficial. So we can construct either an either or situation or decide what our combination therapy would be about.
And it's very valuable, your opinion, because you interpret images from different centers and you can see different treatments or approaches. And as you told me, you don't know exactly which one is the best, but you think that there's something happen with the breast that could be helpful for this woman. Very good, very good. It's a great research for us to think for the next year, try to do something on this way.
Yeah.
And does anyone have any question?
I guess Margaret was waiting for her turn to
go ahead, Margaret. If you want to say important, it's not here. Margaret is no more here.
Eu fiz
yes.
Eu fiz reposição hormonal durante 5 anos, subcutâneo, aqui na Bahia.
Ok.
No último ano eu percebi algo estranho, justamente nessa região aqui, olha. Dá para ver?
Não, Margarete, faz a pergunta para o professor e eu traduzo para ele. Qual que é a pergunta?
Sim.
What's the question?
Na verdade, eu quero mesmo como acessar este material dele para eu ler com calma, porque eu não sei bem o inglês, assim, sou bem primário.
Okay. Tá bom, você quer material.
Eu me inteirar do que aconteceu, mas tudo que ele disse foi exatamente assim.
Ok.
Exatamente.
Dr. Kane, she is asking if you have any website or if you recommend a website with some initial or some information about that, or if you want to send us, and I send to the others.
Are we talking about information on the treatment approaches or information on
the treatment? She wants a little about thermography and treatment. Much more about the treatment, she asked.
Yeah, I can. Let me come up with a list of some resources, and I can send it to you, Dr. Brielski, and then if you don't mind, you can disseminate it to anybody that's interested in it, or just pass along their email addresses. I should put my email address in the chat if anybody wants to contact me directly, and of course, Dr. Brielski's got that as well.
Okay, no problem. So anyone can contact Kane or contact me. I share with you. Sure, there are many papers, so it's just a basic one to start and trying to study more about that. And so thank you so much. It was an amazing meeting. I'm very glad that every Saturday we are learning much more and changing informations with different groups. And I'm very satisfied that we how the information is more clear for everyone. So if you continue doing this every Saturday, most of us will be more talking the same language or understanding that we have solutions, but also we have problems to be solved, and we'll be better if we solvers put together these things for to have a good approach on near future of with our patients. And Sergio, do you want to close here?
Okay. Thanks so much for new 50 minutes in medical terminology. Amazing exposure and sharing the Professor Robert Kane. Thanks so much for everyone. We see next week. Please enjoy sharing this important communication from infrared imaging around the world. Thanks so much for everywhere. Thanks so much for Osprey, Professor Robert Kane, Professor Elizabeth Vilela, many others, neighborhood for ophthalmology to work together for the future on the patients.
Thank you. Good weekend to everyone. Bye bye. And my flight is delayed. I'm waiting. Thank you. Bye.
Bon voyage. Bye.
Thank you, Kane.
Thank you very much.
Thank you very much, Dr. Kane.
Jane, Kylie, Kelly, Cheryl. Oh, many people here. Eh? Very good, Ken.
Good, thank you. Did I mess up on the time?
Sorry?
Did I mess up on the time? I thought we had said 10 a.m. Eastern. So
I told 10 p.m. 3 a.m. East. Is EST is wrong?
Yeah, when you texted me, it was 9 a.m. It was an hour earlier.
Oh, sorry.
That's okay. We had a few people jump on later on, but we've got this recorded, so we're good. I just I felt terrible making people wait for me, so I just wanted to be acknowledge that.
But we found the better hour is this one that we started with you.
Yeah.
Not today. Yeah. Okay. Bye.
Bye.
See you on Monday. On Monday we talk and we return to talk. I have news. Thank you.
Sounds good.
Bye.
Bye.
Dr. Kane, it was only because you wanted to give me the time to do my presentation. That's why you joined later. Thank you.
Well, I'm so glad that it worked out. I'm so glad that it worked out.
Yeah.
And I'm looking forward to seeing your presentation on the recording, because I felt badly that I missed it as well.
Oh, don't worry. We will share it with you. No problem. So you will share with us a link in order to find out, to be able to read more about your work?
Yeah, I'll send you my website, and I'll send some research materials on just some of the nutritional things that has been worked on. I don't have any published papers, but I can send you some of the preliminary work that's been done, and we can kind of take things from there.
Oh, thank you very much. That's great. We appreciate it.
Yeah, of course. Okay, bye-bye.
Bye-bye.
Bye.